Welcome to The Spine Guy. I'm Dr. Brian Sue, a fellowship-trained spine surgeon in Marin, California. The Spine Guy is a channel dedicated to making the complex spine simple for patients to understand. Many of my patients ask me about the Tiger Woods surgery. Well, today we're going to take you into an actual operating room, not of the Tiger Woods surgery, but of the same surgery I performed in one of my patients last week. And that is an ALIF, or Anterior Lumbar Interbody Fusion, which involves taking the disc out from the front and fusing the spine between the L5 bone and S1 bone. I'll be posting new videos weekly, so hit the subscribe button to catch them as they come out.
This is an anterior lumbar fusion setup, and we have David, the scrub tech here. David, say hello.
Hello.
All the people in the
David,
room.
Dr. Sue's spineless.
Okay, and then we have Casey, who's our scrub tech. Say hello.
Hello.
Casey, why don't we show them the instrumentation for an anterior lumbar fusion? Let's see what we got here. We got a ton of instruments, and we have, here's a good example of the implant. That's how it goes in. And look at all these trays. All this stuff needs to be opened just to put in one little implant.
Every surgery room has a rep.
Striker up, Keegan.
Representative of the company, make sure that we are using the instruments the right way. And we always have C-arm. C-arm is basically x-ray guidance. We always mark out the incision with permanent marker. It's being prepped. We use alcohol, betadine, and we use a final prep called chlorhexidine. And we have anesthesiology. Anesthesiology keeps the patient safe. They intubate the patient. Critical to any surgery is the neuromonitoring person.
Good morning, everyone. My name is Alejandra. I'm the neuromonitoring technologist.
So she's got all these fancy wires and cables. Alex, where do these plug into? Let's see.
So this is like
She's going to explain
little
what she does.
acupuncture. So I have these little tiny needle electrodes in the patient. For this particular case, the legs, because you are working at L5 S1 level. So pretty much I'm just running a bunch of evoked potentials. For this particular case, EMGs, sensory evoked potentials.
So watching the nerves, and all these
Watching the
leads go into the
connect
legs,
to
right?
these little pods here that connect to an amplifier that connect to a
It is
laptop.
so fancy.
And then I get tracings on my laptop.
She's so fancy. How much do you love your job, Alex?
I love it so
Alex,
much.
how great is it being in Dr. Sue's operating room?
It's very great. Have you seen my window? I can see the mountains.
Alex has a window.
With every anterior lumbar surgery, we have a vascular surgeon. That's because there are blood vessels that we explained in the prior surgery.
This is the world famous Dr. Laura Pack, the one and only. Dr. Pack is a vascular surgeon because there are blood vessels in the front of the spine, so she does the surgical approach, and she's going to make sure that everything in the front is safe before I do the bony work. Say hi, Dr. Pack.
Hi, Brian.
A lot of people think the whole operating room is sterile. The only things that are sterile are, in fact, the things that have been prepped, draped, and in this blue sterile drape that you're going to eventually see. Sometimes we use a microscope to operate. I always wear loupes. These loupes are 3.5 millimeter magnification. My loupes, this is what the loupes look like. And you basically just put them on your head. And once you put them in your head, it allows you to see. Before every surgery, the government, and just good practice, makes us do a timeout. That's to make sure that if you're operating on a knee, it's on the right knee. If you're operating on the spine, you're at the right lumbar level. So we do a timeout where everyone's listening, everyone's quiet. We're gonna go scrub our hands. But before that, we're actually gonna do a timeout. This is a good example of a timeout. Where's the patient's chart? So before every surgery, we do a timeout to make sure we're operating on the right patient. So we're going to have to bleep this patient's name out during the editing, but this, she's a 35-year-old female. We're doing L5 S1 interbody fusion. Antibiotics?
It's 2 rounds of Vascular in the Vanco is finishing up.
So answer the Vanco pain protocol. Decadron, ketamine, magnesium. Okay, so we're going to need to relax for the first half hour during the exposure.
Yeah, I'll
Right? And we have the implants here, the striker implants here. Where's the BMP? It's a small BMP that has to be open.
In the room.
Okay, master graft has to be open.
Open.
Laura, this is a standalone 5-1 with screws, okay?
got it.
anything else. Those are the correct images. Okay, everyone introduce themselves one more time and what you do.
My name is Melissa, I'm X-ray tech.
I'm Bill Maeda, I'm the anesthesiologist.
I'm Alex, Neuro monitoring.
Laura Pack, vascular surgery.
Casey, scrub tech.
And David, I'm a circulating spine nurse and I have 2 units of blood in the room.
Okay, Dr. Seuss Spine Surgery, and the man behind the camera is the striker rep. Everyone agree?
Great.
Okay, good. So timeout is 8:09.
Anytime your hands are scrubbed, so we scrub our hands for 3 minutes with soap, clean nails, clean arms all the way up to the elbows and wash them. You'll see now I'm using a blue towel to dry my arms. That blue towel is also sterile. And in theory, the back of the gown's not sterile, but we try to make it as sterile as possible. So you'll notice that I step into the gown here, somebody does me up from the back, and then I'll use a tab and spin around. I've never actually seen myself in a gown, but I look super large, like I have a giant cloak on, which is kind of bizarre. We use blue towels always to drape off the sterile area, so these blue towels are folded on one end and then placed over the sterile wound. And you'll see after this that we'll use this plastic substance called Ioban. Ioban is something that almost all surgeons use. It's an iodine impregnated sticky substance that gets stuck over the entire wound. Those are the blue drapes that are sterile. Anything that touches that blue drape from now on for the surgery is totally sterile. This is just putting the clamps on. The clamp is to hold the retractor ring, because ultimately when we put blades in, we have to retract the abdomen. There you see us putting little pouches on. And then you'll see KCR Scrub Tech bring over all at once all the things we use. So typically in that little bundle that he's grabbing is going to be a bipolar cautery, which is an electric cautery that we use to cut. We don't, we use a scalpel for the incision, but we use electric cautery for the rest of the surgery. And there are tubes, suction tubing, as well as other forceps and things like that. You'll see us putting on the light handles. Light handles are these green handles that are sterile. These get thrown away at the end of every case, but essentially allows us to grab the handle so it's sterile when we do surgery. Here I'm checking with anesthesia, everything's okay. We have our Scrub Tech Casey bringing all the instruments and tools up. So we've already made an incision. The incision is over the left lower abdomen, as you saw. And now that we essentially have the disc space exposed, we put this oval ring on. It gets attached to clamps we used to use. And you'll see us grabbing these blades. And what these blades do is they are able to retract some of the abdominal contents to one side, and they get clamped into place. At this point, Dr. Pack is now working around the blood vessels. She's tying some of the blood vessels off. You see her with a very small string. There's a small blood vessel in the front of the lumbar spine that's easily tied off. The movements we use, as you can see, it's a small, delicate area. So when we expose the spine, there's these little movements. I'm holding a sucker in my left hand. I'm actually using the left hand to dissect. We have to make sure that the implant that I put in is going to sit center. So here what I've done is I marked the implant off with a little needle to make sure I'm center. And this x-ray is called an AP x-ray, which is a front back x-ray. So what I do is, in order to start the discectomy, I take a knife and essentially use a knife to cut through the front of the anterior lumbar spine, and that's what I'm doing here. And those long instruments are long pituitaries, and you'll see the knife coming in here. It's a long handle knife because a little bit of a deeper wound. But once I cut, I can then use these instruments called pituitaries. They have little grabbers at the end.
Small pituitary, please. So now we can actually show what the disc looks like. There's a disc coming out. That's a little piece of disc. Okay. Yep. So she has a lot of disc degeneration.
I'll take curettes, then curettes to actually curette the disc out. These are tiny, tiny baby curettes that I use to go into the entire disc space. This is bone morphogenetic protein. Bone morphogenetic protein looks exactly like this. Essentially looks like little flat pieces of white cardboard paper, and they're soaked with this chemical called BMP. BMP is a very powerful bone growing substance. In some other studies has been shown to have a loose link to cancer. The dose we use it at, it doesn't. In order to really get bleeding bone in the implants, and what ends up happening is once we take the disc out, I have to rough up the bones to make the bones bleed so that the bone can grow through and through this implant. And so I have to rasp the end of the L5 and S1 bone.
Anterior height.
You see me hammering the rasp.
But the posterior height is...
And the rasp is basically a gritty metal instrument that's used to rasp the entire implant.
Let's put the trial in.
Take a look, please.
Take a look extra. Is this straight up and down to the sky?
There's a trowel we use. The trowel is a metal trowel that essentially is the shape of the actual implant that we put in. So I take the BMP and I basically load it into this cage. So the BMP gets filled into the cage and the cage gets inserted into the front of the spine, like so. And as it's inserted into the front of the spine, hopefully the BMP stays inside the cage and ultimately the bone goes through and through.
So here's the cage going in.
Six, 7 is essentially taking this screw and driving it through the cage, essentially into the bone. Here's a picture of the screw going up through the cage into the bone.
This patient got a perfect surgery. Laura Pack did an unbelievable job with exposure, one of our more difficult cases. And now x-rays coming out.
To make sure that the implant is perfectly center in the disc space. There's little markers in this particular cage where there's markers in the front and back of the cage, so when you get an x-ray you can see the lines in the cage, and there's also markers on each side.
And now Dr. Pack is going to do the best wound closure you've ever seen for this nice young woman.
The closure of the wound is usually done by the vascular surgeon, and here you see Dr. Pack closing the wound. The wound is usually only about 4 inches long, is closed with what's called a subcuticular suture or a plastic surgery type closure. It's done with suture as fine as fishing wire that's totally dissolvable, and then we put these brown band-aids over them called steri strips that also just naturally fall off over time. Thanks for watching. Hopefully you enjoyed this very unique trip with me into the operating room for an anterior lumbar interbody fusion. Don't forget to click the like button and leave questions or feedback in the comment box below. Feel free to let me know what videos you would like to see in the future, and if you'd like me to take you into the operating room for other types of spine surgery.